Today, we're going to be talking about what chronic lymphocytic leukemia patients should know about Richter's syndrome with Dr. Erin Parry. This topic was chosen because Richter syndrome or Richter transformation is a rare but serious transformation of chronic lymphocytic leukemia to a more aggressive lymphoma. And we are lucky enough to have Dr. Erin Parry with us today as she is an expert in this topic. So, Dr. Parry attended Johns Hopkins University School of Medicine, where she earned an MD, PhD. On graduation from medical school, Dr. Parry completed residency training in internal med at the Johns Hopkins Hospital, followed by medical oncology fellowship at Dana-Farber Partners Cancer Care. During her fellowship, Dr. Parry conducted postdoctoral research in the laboratory of Dr. Catherine Wu on Richter transformation and chronic lymphocytic leukemia. Dr. Parry is currently an assistant professor of medicine at Harvard Medical School and a physician at Dana-Farber Cancer Institute in the lymphoma program and the Center for Chronic Lymphocytic Leukemia. She runs a laboratory focused on transformation of indolent B-cell malignancies to aggressive lymphomas and mechanism of immune evasion in CLL and B-cell lymphoma. And we are so happy to have you here with us today, Dr. Parry. And with that, I'm going to turn it over to you.
Wonderful. Can you all hear me okay?
We can.
Okay, I'm just going to go ahead and share my slides. And it's an honor to be here with you all today, talking about this topic, of which I do a lot of research on, which I think is also sort of on a lot of people's minds. I'm going to be talking today about Richter's syndrome or Richter's transformation. So just to outline some of the areas that I'm going to highlight in my talk today. First, what is Richter syndrome, where we get this name from and what it actually represents. Talking about how it would be diagnosed in different types of transformation, how we approach thinking of treatment of Richter's transformation in the current era. What is new and exciting in clinical trials that we'll learn about soon. And then also what we've come to appreciate in the last couple of years about the science and underlying biology of transformation. So what is Richter syndrome and where does it get this name? So to start, as many of you are aware, and perhaps how things often get named in medicine is it's named by someone who initially described it. So a pathologist by the name of Maurice Richter first noticed these sort of abnormal large cells that were contained within a lymph node of a patient with chronic lymphocytic leukemia that didn't follow the sort of small, more organized cellular appearance of CLL cells in the lymph node. And he published this description back in 1928. And this is the sort of earliest description that we have of this entity, which we also now call Richter's transformation. And this is the entity that is now favored by our pathology organizations. So this is used interchangeably oftentimes with Richter syndrome in the literature. And the other term that also represents the same exact entity that you'll sometimes hear is people refer to histologic transformation of chronic lymphocytic leukemia. So now that we have all these names, what exactly does this represent? So histologic transformation, I really think of as sort of an extreme form of cancer cell evolution. We know that cancer cells sort of all start from the same cell and they share many things in common, but they also grow and change over time and adapt to therapies. And we're all familiar with these concepts of evolution and resistance. Transformation is when cancer cells actually switch their cancer cell type. So they start as one cell type and they can actually transform or change into another cell type. And this is something that we see in a lot of our blood cancers, but something that we can also see even in non-hematologic cancers. So this can even be seen in things like lung cancer and prostate cancer. And sometimes it's a way in which cells sort of escape a therapeutic pressure, so how they gain resistance to a therapy. Other times it's just a way that the cells sort of acquire characteristics and ability to sort of grow more rapidly. And when we find this in the setting of chronic lymphocytic leukemia, we call this a Richter syndrome or Richter's transformation. And so clinically, we define a Richter syndrome or Richter's transformation anytime we see an aggressive lymphoma in a patient with a history of CLL. But operationally, what we're really talking about and what we're really thinking about is the CLL cells sort of becoming this aggressive lymphoma. So this, despite sort of maybe some of the attention it gets, is actually quite a rare event in CLL. So the majority of patients with CLL do not experience Richter transformation at any point in their disease history. The minority of patients have this happen as a complication. One of the sort of emerging evidences of or emerging sort of areas of research is there was some data actually presented last year at our annual meeting, ASH, in December, that actually suggests that the incidence may even be lower now that we're using sort of our novel therapeutic agents and less chemotherapy approaches. We know that novel therapeutic agents don't completely sort of prevent Richters, and we're still seeing Richters, and we even still see Richters in some patients that have not been treated for therapy. But perhaps it might be that we're starting to see less of it compared to prior. And this is something that we need more time to really figure out so that we can get more data in this area. But I think it is a reason to maybe have some optimism as well. And on the slide here, you can see that this is an example of what we're talking about when we're looking at a biopsy sample of Richter's. So this is showing an area of sort of the more small cells of CLL on the left going to more the open, larger cells of Richter's, where you can see that they have bigger sort of centers of the cell, which we call nuclei, and the cells themselves are also bigger, and it looks maybe a little less organized in appearance. So sometimes I'm asked, can we predict Richters, or do we know who's likely to get Richters? And the short answer is no, we do not have a way currently of predicting Richters. We do recognize that there's a number of risk factors. The way that these have been found is looking at large series of patients at different institutions and looking for what things might associate with an increased risk of Richters in the future. You may recognize a lot of the things that are on this slide as actually being things that are actually more than being truly associated with Richters are actually associated with some of our higher risk CLL. And we know that the majority of patients with high risk CLL don't get Richters. So these are not predictive, but we do know that there's some disease features that can be more associated than others. And again, these are generally marking the same types of things that we think of with CLL prognostic marker testing that might put someone in a slightly higher risk category. So even if you have one of these features, it does not mean that you're necessarily going to develop transformation in the future, because only a small fraction of our patients have that happen. A lot of times people ask me, what do I look for, or when should I suspect transformation? And I actually tell people not to necessarily look for any symptoms, but that they should let their doctors know if there's a big overall change in their health anytime once we know that they have a diagnosis of CLL. And this is mostly so that we can be aware of things that are going on and help, not just because we're interested in looking for transformation. So some of the things that make us think about transformation, or that may indicate that we should consider it, among other things, are someone who has the sudden onset of what we call constitutional or B-type symptoms. These are things like really drenching night sweats where you're changing your clothes multiple times per night, significant unintentional weight loss, or fevers without a known cause. We also sometimes can see people with really dramatically abnormal labs. So this would be something like a very markedly elevated LDH or high calcium level. We may also notice rapidly growing lymph nodes, especially if it's sort of, asymmetric in appearance, or, only a subset of lymph nodes that are growing, or lymph nodes that are growing without sort of seeing that progressive lymphocytosis that we expect with CLL, meaning the white blood cell count gradually rising as we expect with often seeing in CLL progression. And then if someone who's doing really well is suddenly not doing well, and we don't have an explanation for that, that sometimes also gets our attention. None of these are specific for transformation, though. So these all symptoms could also be attributable to other entities too. And so therefore, we really, really need a biopsy to establish a diagnosis. So if you present to your physician and someone has symptoms like that, it really just starts us down working up the underlying cause of these symptoms, and sort of maybe moving towards getting a biopsy or sample of material to sort of figure out what is going on. We often get a specialized CT scan known as a PET CT scan that can help us highlight areas of CLL and lymphoma in the body. These scans are not enough to be diagnostic of transformation. And that is because in this era of targeted CLL therapies, we know that we can sometimes see quite high uptake on scans, especially post-treatment in CLL patients, that is actually not transformation. So we still need the biopsy. but the scan can sometimes be helpful and because it can point us to certain areas that would be more high yield to biopsy. So it may actually help direct the sort of clinical approach for biopsy. And if the scan shows very low uptake, that also can be reassuring that we're not looking at transformation if the uptake on the scan falls below a certain level. So why do we proceed with a biopsy? And why is it so important for us to do that? Why can't we just treat on clinical suspicion? And that is actually because we see different types of transformation as the first reason. And the second reason, as I'll talk about, is because other things can also sometimes mimic transformation. So, among the types of transformation, the majority of transformation, and that's what I'll spend the most of my time and the remainder of the talk focusing on, since that's what we see in the majority of cases, as a type of transformation to a large B-cell lymphoma. We sometimes abbreviate this DLBCL because it is diffuse large B-cell lymphoma-like. That's the sort of histology or appearance under the microscope to our pathologists. This is when CLL is replaced by those sort of sheet-like proliferations of large cells, like that image I showed you previously that you can again see reproduced here. This represents about 90% of what we see for Richter's transformation cases. We also see a smaller percentage of Richter's transformation cases that is still a well-recognized subset in which the transformation is to a type of lymphoma called Hodgkin lymphoma. This is also a B-cell origin, but has this characteristic of appearance of a very large cell with prominent nucleoli. And you can see an example of that sort of in the center of my slide, if any of you can see my cursor. And it's sort of in a field of CLL and inflammatory cells oftentimes. And then the last type of transformation is sort of other rare types of transformation. And this can include transformations like plasmablastic lymphoma. So one of the reasons that we need to get that biopsy is actually to kind of figure out what type of transformation, when we suspect transformation, if it is indeed a transformation. And then we treat based on the type of transformation. So we treat based on the type of lymphoma that we find on that biopsy. And so since our therapies are tailored and we could end up in very different directions, treating towards a large cell lymphoma versus treating with sort of therapy that's directed at a Hodgkin lymphoma, it's really important that we have enough tissue to be able to make that determination. And the other entities can also sort of sometimes mimic transformation or look like transformation. So we actually have an entity that some of us sometimes refer to as a pseudo-Richter transformation or pseudo-Richter syndrome. And this is actually something that is associated with a pause in certain types of therapy. So we're really lucky to have these highly active targeted therapeutic agents in CLL now that many of you may be familiar with, a class of drugs called BTK inhibitors. These are things like acalabrutinib or zanubrutinib or ibrutinib. And when patients are on these medications, we sometimes have to hold them if someone's having a surgical procedure due to risk of bleeding and things like that. And if someone's CLL is not well controlled when we do one of these therapy pauses, sometimes we can see a little bit of lymph node enlargement. This is not a transformation, and it rapidly goes away when we resume the drug after the procedure is successfully completed. But this is something that when it was seen sort of by chance in some of these surgical biopsy specimens, it can actually look like large cells and actually look similar to Richter's under the microscope. But we know that this is sort of not a true phenomenon. And so if something sort of emerges in the setting of an unscheduled drug hold or a scheduled drug hold, and it sort of goes away with therapy, this is not a true transformation at all. And so this is something that sort of can mimic that under the right circumstances. We also have cases of more aggressive or more proliferative CLL, and whether or not that's because something sort of stimulated the CLL or if it's sort of a more aggressive disease biology. We can sometimes see CLL with lots of areas of proliferation that they call proliferation centers, or sort of increased larger cells, but that are still CLL cells. They haven't really changed their cell type completely. And these are things that, again, hematopathologists, the doctors that sort of, tell us what they see under their microscope for pathology, can really make this determination, but it requires expertise. Other times we can also see infectious mimics. So there's been patients in the past that have had things, either viruses or things like that, that can, again, sort of cause a constellation of symptoms, including, focal lymph node enlargement and, some of these constitutional symptoms that can mimic a transformation. And in some of these cases, our pathologists can see that when they look at the biopsy and can tell us that, no, this actually looks like such and such virus instead of something that's a true transformation. And then lastly, other cancers. So we also think about risk of other cancers sometimes in patients with CLL. And so many of you have been reminded by your physicians to get things like annual dermatology skin exams and keep up with your preventative care with your primary care doctor. And so we can, always want to get a biopsy to make sure that we're treating the right thing as well. And so really a hematopathologist is an essential part of our clinical team. And it's someone that you may not meet when you come to the hospital and you're meeting with your physician care team here, but they really help us out a lot behind the scenes. And we really rely on them to tell them what we're looking at. So this is something that we're really lucky to have expert hematopathologists at these academic institutions that many of us get to work in. And they really, really, really do make a difference for our patients. The other thing is sometimes there's talk about making sure that we have a biopsy of enough size too. So I just wanted to, before I move on to this next slide, also mention that some of you may have been through an experience where the doctor recommends a biopsy and a needle is done, and they come back and they say, we think we see something, but we need more tissue. We need a bigger biopsy. And that is sometimes because we need to get those areas of tissue architecture for our pathologist to make these determinations. So it's not meaning that something has gone wrong, and it's not sort of an unexpected result when we're talking about lymphoma diagnoses and CLL diagnoses, if sometimes we need a little bit more of a bigger tissue sample. This is something that we have to do quite commonly, and it also doesn't mean something is necessarily transformation. It just means that sometimes the little needle fragments aren't enough for them to make the determination of all the things that they need to look for to make sure that they're doing the right thing and coming up with the right information for you and your doctor. Other things that, biopsies can tell us sometimes is this idea of relatedness. So as some of you may have recalled on that first slide, I say that we define a Richter syndrome or Richter's transformation when we see an aggressive lymphoma in someone who has a history of CLL. And we assume that the aggressive lymphoma is coming from the CLL, but we actually, when we think of large cell lymphoma type Richters, can actually see it in both ways. We can see Richters that directly comes from the CLL cell. They're related. The Richters is actually sort of evolving from the original CLL. And that is the majority of what we see. And we call this clonally related Richters. But there's a subset of cases where Richters and CLL are actually separate sort of B-cell malignancies, and that we don't see shared genetics between the Richter cell and the CLL cell. So they're actually a separate sort of CLL evolving separately, and then a B-cell lymphoma evolving separately. And this is what we call clonally unrelated Richters. And so this is something that your doctor may try to test for if they have the right samples available to be able to inform, subsequent decision-making in the clinic. But this is something that really only can also be done if we have, the right material. And it's not as easy as it may sound, because we also have to have a good CLL sample to compare it to. So how do we approach treating transformation in the clinic? So this is sort of based on a summary of the guidelines currently for sort of how we approach treating transformation. And this is something that's sort of agreed upon in multiple guidelines, is that if we have someone with known clonally related transformation or transformation of unknown clonal relatedness status, which is honestly the majority of what we see falls into the unknown category, then we prefer approaching with a clinical trial if someone's a good candidate. And this is because the standard chemotherapies that we use for diffuse large B-cell lymphoma, things like that are listed on the second line, haven't had as great response rates for patients with Richter's transformation of CLL when we know that it's a true transformation. And so we think that the clinical trials offer a true new advantage. And we also have a lot of new lymphoma therapies out there now. So a lot of these new combinations actually may offer a good advantage over sort of the traditional chemotherapy backbones. So if you or anyone that sort of, is diagnosed with Richter's ever, it's a great opportunity to try to see what clinical trials might be in your area and if any of them are a good fit with you when you talk to your doctor. We also have sort of the historical standard had sort of been using these anthracycline-based chemotherapy regimens. And if patients do achieve a remission or a good response, so if we're able to sort of get a scan where we don't see evidence of the aggressive lymphoma around anymore, we often do consider doing a hematopoietic stem cell transplant or a bone marrow transplant, because this offers long-term opportunity to keep that lymphoma at bay and from not coming back. So this is sort of our best opportunity. So we often think of something, and we call that sometimes consolidation transplant, to really get rid of the aggressive lymphoma for good. If we have someone where we know that the CLL and lymphoma actually came from different cells of origin, and that it's really unrelated, then we often treat with sort of our large cell lymphoma type regimens, which are more the anthracycline-based chemotherapy, and feel that that's enough treatment, because it's sort of not the same as the CLL. There are some things that, we can look at for prognosis in Richter's, but you can see that the list for prognosis in Richter's is probably a lot less than what you've seen in the past for CLL. So since CLL has been so well studied, we know a lot about different risk factors in terms of clinical and biological and genetic risk factors that sort of can help us, provide individual information to each of you. In Richter's, we know less about that, but we do know that there's some things that associate with better prognosis, including if we know that the clonal relationship status is unrelated, or if people have not yet been treated for CLL, or if people are in really good health otherwise. So people who are younger, in good performance status, which is an oncology way of saying that they're very fit and healthy, and people that sort of respond to that first line of therapy, that gives us a lot more hope that those patients are going to do better with the different chemotherapies and be candidates for things like the stem cell transplant. And then this is the slide that I think is actually really exciting looking forward and offering a lot of hope for the CLL community. And that is that there's a lot of really active clinical trials in Richter syndrome or Richter's transformation right now. And even this compared to about 5 years ago, I think the space has changed dramatically. The medical community has made a lot of progress in terms of CLL therapy in the last 10 to 20 years. We've had multiple new highly active targeted agents for CLL and moving away from chemotherapy. And I think a lot of our really talented clinical investigators are now trying to really make a difference in this area as well. And so there's a number of really exciting different strategies that are being employed in clinical trials right now. One of the strategies that we're seeing is sort of using some of the CLL targeted therapy in parallel to that sort of chemotherapy backbone. And an example of this is venetoclax R-CHOP, which has already been reported to show some promising data, and which is also sort of an ongoing active trial that we'll hear more results from in the future. Acalabrutinib plus R-CHOP, which is another active ongoing trial that we'll hear more information about soon. And then combinations of different targeted therapy agents. So the idea of getting away from sort of chemotherapy and being able to sort of use different combinations of therapies is another strategy that's being explored through different trials. And then the last category is really taking advantage of some of our newer therapies in the lymphomas, and that is really using these immune-based strategies. So many of you may be aware of CAR T-cell therapies, which are these engineered T-cell therapies, which also sort of are being are approved in patients with CLL that have had certain prior therapies. And we know that these therapies are effective in Richter syndrome from sort of looking back studies that across different academic medical centers. And one thing that we have seen, though, is that even though these therapies can be effective, there's definitely side effects. That they could be effective. We would like them to be effective in more patients. So some of the active studies are now trying to see how we can improve upon CAR T cells with different strategies to make them more effective for both CLL and Richter. There's also a number of studies that in recent years that have come out focusing on immune checkpoint blockade. These are sort of the different immunotherapies that take the brakes off the immune system and re-engage your immune system. And so taking advantage of some of those therapies in combination with different CLL therapies to sort of re-engage the immune system. And then the last sort of group of studies to highlight is that we have these new active agents in lymphoma called bispecific antibodies that sort of help bring the immune system's killer cells, which are your T cells, in close proximity to the tumor. And these are approved in certain lymphomas already in later lines of therapy. And some of the initial studies that led to those approvals did contain small numbers of patients with Richter syndrome. And it does look like there's evidence of some early signal in some of those studies. So a lot of the ongoing clinical investigation is also sort of bringing these bispecific antibodies along with different combinations to patients with Richter syndrome and earlier lines of therapy. So now I'd like to switch to talking a little bit more on the research side and about what we know about the biology and what causes this sort of rare event of histologic transformation to even occur in the first place. And so I think there's a certain number of challenges to studying transformation that are different from what we think about with CLL. So CLL has been one of the more genetically well-studied cancers. And I think this is in part due to the wonderful commitment of patients with CLL to research, but also the fact that this is generally a slow-moving B-cell malignancy that people have for many years, and it can be obtained through a peripheral blood sample. So with careful and thoughtful patients willing to participate in research, samples have been able to be collected over the time course of many, many years to understand how things change over time so that we can understand resistance to therapies and sort of what determines outcomes to different types of therapies. In Richter syndrome, mostly the cells are not usually in the blood. They're mostly residing in lymph nodes or in bone marrow tissue. And so because of that, we really need sort of a non-blood sample in addition to the CLL sample. And we also need the CLL sample to compare to really be able to understand the relationship and if they're related and understand what changes are sort of in which cancer cells. In addition, when we do a biopsy, it often looks more like this picture than the top picture of the cells nicely separated. So we often get biopsies where the CLL and Richter cells are all jumbled up, even including normal immune cells in the mix too. And so we have to have either special ways of separating out these cell types in the laboratory or special ways of sort of computationally separating them out. So we can also understand sort of genetic admixture and which genes might be in which cells and what's going on in which setting. And then I think the last area too that we've seen a lot of innovation in the research area is modeling transformation, right? So we can study these really precious, patient-derived samples that, people donate to research science. But also we want to be able to create systems that sort of mimic, the human body and the systems in the human body so that we can be able to understand things better. And historically in cancer, this sometimes comes from looking at cancer cell lines in the lab and something like a cell culture flask, like the little cartoon on the slide, or also for mouse models, where we can sort of understand something in a living organism with a lot of the complicated context and immune environments and things like that. And CLL and Richters don't tend to grow well outside the body, so they sort of require us thinking about carefully so we can develop ways of really understanding what's going on. And so in recent years, a number of studies have been published that have really started to shed light on Richter transformation and sort of what is going on. And so the favorite part of this slide is to look at the dates on these studies. So if we look at what's happened from 2022 to the present, there's been a number of really high profile publications that are sort of starting to unlock clues into sort of basic foundational understanding of transformation. How do genes change? How does the immune microenvironment change? How do we model this in a mouse? And how do we begin to understand therapeutic dependencies and different pathways that'll make us better at treating this? And then also some of the recent work that we've been able to do. So this is now shifting to sharing with you some of the work that I've been able to participate in. Is to look at the genetics and how CLL sort of becomes Richter's. So we completed sequencing of exome, which means sort of all of the genes in the cancer cells, as well as the genome, meaning all of the DNA basically in the cancer cells, including the genes and the areas that are not the genes that sort of regulate the genes. within patients, looking at paired CLL and Richters and normal tissue to really understand what makes CLL CLL and what makes Richters Richters. And we were able to sort of reconstruct these sort of family trees, if you will. So each one of these sort of little colorful things is showing different branches of evolution. And so the majority of cases were like this, where the Richter's was sort of related to the CLL. And so you can see that that green branch is sort of shared. There's a shared green ancestor between what becomes CLL and what becomes Richter's. But in some cases, which were the clonally unrelated cases, the CLL and Richter's were two separate trees. They didn't share anything in common, and they didn't share any common ancestor. And this sort of really confirms what had previously been shown based on sort of sequencing targeted areas called the B-cell receptor. And our work, as well as work of others, went on to show that, you know, these unrelated cases are genetically, epigenetically, and transcriptomically. So the genes and all the gene regulatory programs, they look like de novo large cell lymphoma, and they look separate from the rest of Richter's. This really is a unique subset, and therefore that's why therapeutically they do better when we treat them like diffuse large B-cell lymphoma, whereas Richter's has unique biology, which is why we want sort of these Richter-specific treatments that are better than the standard chemotherapy. And so we've also been able to sort of contribute some other areas and sort of learn some new things about Richter's across different studies. So some of the other sort of findings to highlight is we're able to sort of figure out what was happening early in CLL, in the middle of sort of progressive CLL, and then also close to the time of transformation, and highlighted a number of new pathways and things that are different at transformation that we want to learn more about. We also learned that there's different pathways to transformation, so different combinations of genes and mutations and changes that sort of help sort of lead the cell to transformation, so that not all transformation is also the same. We also could actually start to study things at a single cell level. So these funny plots that you see that are dot-like things, each dot on the thing is actually a single cell. And so as our technologies get better and better, we're actually able to study single cell evolution like at with a bigger and bigger magnifying glass, if you will, so that we can really understand what are the triggering changes that cause that cell type identity shift. And then we also looked in the blood to see if we could see genetic changes of Richter's separate from the abundant circulating CLL. And we can, which is an interesting thought because it leads us to the possibility as we look towards the future of potentially being able to find things and detect things that are different in the body through simple blood tests as opposed to these tumor biopsies that I emphasized are so important for us right now. And so overall, these studies have really sort of highlighted many different aspects of biology. So sort of the genetics or the genes, the things that control things outside the genes, which we often refer to as epigenetics, and also the pathways and different signaling changes within the cells that are altered. And all of these together have given us a new unified understanding of some of the unique features of Richter's, which we hope is going to start translating to us making a difference in terms of understanding how to better target it. And we also are just starting to have big studies that are looking at the immune microenvironment of Richter's and how we might be able to better target our body's own immune systems with cancer therapies. And I think this is really an exciting opportunity looking forward is how we might be able to use the immune system to better fight Richter's. And then also this is sort of a forward thinking slide. So this is sort of aspirational of where I hope that we'll be in the future. And so a number of the studies that have been done recently have focused on different aspects of biology. One of the studies out of the group that's located in Barcelona in Spain found this intriguing finding that they could find early genetic changes of Richter's even years before emergence on a single cell level. And then I mentioned that we were able to find DNA changes in the blood around the time of Richter's. So as our technologies get really better and better, I think an interesting question is if there's a way to predict transformation or monitor more closely for transformation in patients at risk. And if we also can sort of tailor our therapies to an individual's unique transformation characteristics as we sort of understand subtypes better. And if we can see it coming and know it's coming ahead of time, then could we intercept or prevent it so that we can even stop it from occurring in the first place? So while these things are, things that are not possible right now, I think with evolving technology, there's a lot of hope that we might be able to get to these places in the future together. So to summarize some of what I've shared today, Richter's syndrome or Richter's transformation is actually something that's very rare. There's more than one type of transformation, and right now biopsy is an absolutely essential step in that diagnostic process. There's a lot of activity in terms of clinical trials, and we really hope that this is going to improve dramatically our treatment options for Richter's in the near future, and that science is really also advancing in parallel and uncovering novel insights into Richter's biology that we hope will also translate to better therapies and detection in the future. So with that, I want to thank all my colleagues here that I work with on a daily basis, and also wanted to highlight some of the CLL research community that directly contributed to this work. And also thank you to all of you. And I think one of the wonderful things about sort of being involved in this type of research is getting to interact with everyone who cares so much about working together to sort of move towards a cure. So thank you for all of you.
Awesome. Thank you so much for that presentation. That was super informative, and I really liked getting to see where the science is kind of taking the research right now. Not too often do we get a good glimpse into that, so I really appreciate you sharing that with us. So now is our time for questions. I know that we do have a few in the chat already, but just as a reminder, feel free to put those questions into the chat if you would like me to read them out loud, or if you want to ask them verbally. You can use the little reaction button, raise your hand, and then I'll go ahead and call on you and you can ask your question out loud. But that being said, let's go ahead and get started with our questions. So, first question comes from Cindy. Is atypical CLL with deletion 17p at an increased risk of developing Richter syndrome?
Hi, Cindy. Thank you for your question. So we know that P53 alterations, which can be the mutation and or 17p deletion, since we often see those together, is one thing that is associated with increased risk of Richter's, but it's only one of the things. And most people that have that do not get Richter's. So it is not something that means that you're going to get Richter's syndrome. It is only one small risk factor.
All right. And then Mike asks, how rare is it? Can you put a percentage on it?
Yes, so I can, and it depends on which study that we look at. So some of our data is actually sort of predating our current novel therapeutic agent era. So the risk for an individual is less than 1% per year. It's higher in patients that have had prior therapies for CLL based on the chemotherapy treated era. And so it's even less than 0.5% in patients who have not been treated for their CLL. Newer data, like the data that I sort of alluded to that's been presented more recently, actually suggests that may even be lower. The lifetime risk, or sort of throughout the course of your CLL, has been sort of really varied and depending on what sort of cohort or where the study was conducted, but it is definitely the minority of patients overall. I hope that's enough that I answered your question. Did I give you all the information that you needed?
Mike, was that a answer? Yep, perfect. This next question from John is one that I love because I feel like so many people have this similar vein. Is diagnosis with SLL first before CLL linked to an increased risk of Richter syndrome?
So that's also a really great question. And so we know that patients with very bulky lymph nodes, that's something that has been sort of associated with like bulky lymphadenopathy. But or having SLL on its own does not necessarily mean that, because sometimes SLL can be associated with smaller nodes. So it is just one thing, and we still have a lot to learn about sort of, what causes this.
So, all right, we have a verbal question coming in from Lynn. Feel free to unmute yourself, Lynn. Okay.
Am I unmuted?
You are.
Okay. I've really enjoyed this presentation. I appreciate, Doctor, that you've kept it on a level that laymen like me can understand. So thank you for that. Um, I have a question. If you're a high risk patient with Notch1, all the deletions, and you're on a BTK inhibitor that has responded well for, let's say, 2.5 years, at what point um, is there any particular point where Richter's transformation does come into account? Like, is it at the beginning of therapy? Is there any kind of data that shows when it kicks in if you do get it?
That's a great question, Lynn. When the first studies of therapies like BTK inhibitors were first studied, they were studied in patients that had multiple lines of therapy. And so when Richter's emerged in those studies, it was often really soon after starting the medication. Overall, our current studies suggest that the incidence with upfront therapies is very low. So this is sort of looking at the big clinical trials where these medications were all studied, and the incidence of Richter's in those studies is quite low. So I think that even though we're talking about it today, I know that this is something that, weighs on a lot of people's minds as a concern. But the actual incidence of this happening is quite low, regardless of the risk factors.
Okay, because my CLL specialist is extremely concerned about it from really almost day one that I was diagnosed 5 years ago. It's on my mind, but as I progress, it's less on my mind, but it's there. Thank goodness I've been on zanubrutinib and even another BCI. I was on venetoclax for a while. And thank God my bloods are all perfect now, but that the concern is still there with my doctor. That's why I'm asking, it's 5 years. I've been on treatment 2.5 years. I've actually also been up to Dana-Farber. And that's what I'm wondering, if there's any data that shows how long, or it just does, there is no data yet, how long after, being on treatment it comes out.
Yeah, I think everyone's different, and we're getting more data, I think, from sort of, people being treated in the novel agent era, so that we might be able to someday say, for patients exactly like you, we can give you the numbers that you want to hear so that you can be empowered with that information. But I think talking about it with your doctors is definitely the best strategy, because they'll be able to look at, all of your individual information and give you the best information that we have.
Thank you.
And then our next question coming in is, this person just listed as iPhone, but I have common variable immune deficiency, and last year I was diagnosed with CLL. Is my immune deficiency linked with the diagnosis of CLL?
That is a great question. And so we do know that there can be some immune deficiency that is linked with CLL, and that's something that we often test for as physicians, looking at, your antibody levels when you're sort of diagnosed. So definitely something to talk to your physician about.
And then just kind of a broader question. Um, so with Richter syndrome being pretty rare, thankfully pretty rare, um, how important is it for individuals with CLL to at least have a second opinion with a CLL specialist? Is With it being this rare, I feel like not every oncologist is going to run into Richter syndrome frequently and may not know the best plan of attack if they do encounter a case. So, how would you recommend, or would you recommend people find a CLL specialist, or kind of seek out a second opinion?
That's a great question. So I think that around the diagnosis of Richter's transformation, that certainly would be a reason to. And one of the things that you often gain by going to see a CLL specialist is also an expert hematopathologist. So the consult often has sort of a review of the tissue and the case, and that is often one of the better things that we can offer our patients too, in addition to sort of our specialty knowledge. So that is something that I think can be. I think it's also really great around any conversation around initiation of treatment for people that are doing really well and are in a watch and wait period. I think if someone is really starting to say, I think we should end the watch and wait and move forward with treatment, that's another great time to really consider it, just because of what the clinical trial landscape is there's often something that might be an advantage that may be a clinical trial, and you might hear sort of different opinions on therapy options and make sure that you're sort of making the most informed decision for you. So I think surrounding therapies or surrounding any sort of big shift in the conversation, that's a great time to sort of get some additional input.
Excellent. And then this may be our last question, unless another one rolls in here shortly. But Tom says that my CLL transformed in June of 2022. I completed 6 cycles of R-CHOP and had complete response. Now, 2 years later, I am still in remission. Congratulations. My blood tests are normal and I feel good. Do you suspect that my DLBCL is clonally unrelated?
That's a great question. I can tell you're paying close attention. Tom, congratulations. I'm so glad that you're doing well also. It may be, that is something that you could ask your team about, if there's sort of material that they could even test that for you if you're interested in knowing. More often than not, we don't have that information at hand because we don't have enough, things saved that we can send the testing. It's actually not always easy, since we need a CLL sample and a Richter sample. So we have many patients where we're not able to give them that information, and it's always sort of our best guess. And sometimes your individual physicians may have, an opinion or be able to look at your unique case and offer their best thoughts. But we often don't know. And I'm really glad that you're doing well.
Yeah, we all are. All right, I think that's going to wrap up our question section. Or let's see. Perfect. Yep, that's going to wrap up our questions. So thank you, Dr. Parry, for answering all of those and for this wonderful presentation. Before we go, I do want to highlight how to connect your records in HealthTree Care Hub. After creating a HealthTree Care Hub account, you're able to electronically connect your records from any facility into your profile. Once your records are connected, you can now view a comprehensive overview of your medical history, including your diagnoses, your genetics, lab results, treatments that you've been on, all within a single user-friendly interface. It only takes a few minutes to create the connection and to start taking control of your diagnosis. On the screen, I have the link to sign up for the HealthTree Care Hub, along with the email of our amazing patient navigators who are available to help you create an account and connect your records. I will also include information about how to enroll in HealthTree Care Hub in our follow-up email, so be on the lookout for that. And then this is special for this time of year, but I'm going to take a moment to share something really exciting with all of you. One of the most powerful things about our community is how we can come together to make real change happen. Right now, we have the incredible opportunity to advance blood cancer research. We are currently working on 100 research projects that will help change lives. If you feel called to participate, you can contribute in 2 meaningful ways. First, you can share your medical journey by joining HealthTree Care Hub Registry, because your experience matters and can help researchers understand patterns that they might never otherwise see. And second, if you're able to, through a donation and sharing this fundraiser with your family and friends, all donations will go directly to research. In our follow-up email, you'll receive links to the HealthTree Care Hub and how to donate. Thank you all for being an integral part of our community. It is our goal to make meaningful change in your lives through this initiative. We will have some upcoming events, likely for January. So we are in the process of planning and finding speakers for those events right now. So we do have more coming up. But as you leave today, we'd really appreciate if you took a few moments to fill out a brief survey about your experience and give any suggestions for future topics that you would like to see. the best part about hosting events is hosting events that the community cares about. So please fill that out. It really does help. I don't want to waste anyone's time here by showing an event that no one cares about. So if there's something you'd like to see, I would love to hear about it. And finally, I just want to say thank you all for helping us build our CLO community. I've added my email address to this slide. Please don't hesitate to reach out if you have any questions about HealthTree or any of our programs, or even if you just want to talk. I love having the opportunity to talk to members of the community and hear about your stories. So I appreciate you all, and I hope that you have a great rest of your day, and I hope to see you at another webinar soon. Thank you.